Hello, everyone. I'm Dr. Rita Roy, CEO of the National Spine Health Foundation. Welcome to Spine Talks. I'm delighted and honored to be part of this conversation today, a really remarkable conversation with Dr. Raj Sethi from our Medical and Scientific Board and the multidisciplinary approach he takes to optimizing patient care. We're joined on the panel today with his patient, Mr. David Larberg, and his PA, Ms. Michelle Gilbert. So with that introduction, I'm going to invite our panelists to introduce themselves. Dr. Sethi?
My name is Rajin Sethi. I'm the Director of Neurosciences and Spine at Virginia Mason Medical Center here in Seattle, Washington. That includes directing the complex spine program.
My name is David Larberg. I'm 61 years of age. I was diagnosed with scoliosis in my mid-30s. It wasn't a problem in my mid-30s, but it became a problem later in my life. And I seek some attention to get it repaired and fixed. I didn't like what I heard, and I got a second opinion, and this is what brought me to Virginia Mason, and that's where my journey started.
My name is Michelle Gilbert. I'm a physician assistant here at Virginia Mason, and I lead the patient-facing portion of the patient evaluation in the complex spine program, and I help run the multidisciplinary efforts to our program here.
We're so excited to talk about many aspects of the patient journey. It's truly an honor to have David with us today and joined by his surgeon who performed this very complicated surgery to correct the scoliosis that began to bother him in his career. We're going to talk a little bit about his career as a firefighter and what that meant to be able to get back to work. So one of the things we'll start with is just, beginning with the awareness, how you know you have a problem and where do you go to begin seeking care. And so we're just going to start going down that pathway, and I'll turn it over to David.
I wasn't diagnosed until my mid-30s, and it was kind of by chance. I was very active in my 20s and 30s playing, basketball and pickleball and racquetball and biking and running and doing all sorts of things that I like to do. And I started having some low back discomfort. I thought it was quite normal to have that. But my wife, she was getting chiropractic work done, and one day I went along with her, and I met up with the chiropractor. He was a good friend of ours. He says, "How you feeling?" I said, "Well, I had some low back pain." He said, "Pretty normal."
Yeah.
And they said, "Why don't you come in? We'll take a peek at you." So he did an evaluation on me, and first thing he did was did X-rays, and the X-rays came back, and he says, "Do you know you have scoliosis?" I said, "No."
Awareness.
I had no clue. I've always been told, though, that my hips were a little off. People said, "Yeah, you walk a little funny, like one hip's lower down." Okay. So I talked to the chiropractor. I said, "What do I do about it?" He said, "Well, if it's not bothering you, keep doing what you're doing. Stay active." So I did. Well, fast forward 20, 25 years, things started bothering me. They really did. And it got to a point where I was in chronic pain all the time. It hurt to sit, stand, walk, everything hurt, and it just wouldn't go away.
Did it interfere with your work?
It did.
Yeah.
Again, being in the fire service, you need to be active and be ready to go at any moment.
Yeah.
Luckily, later in my year, I had a staff position where I did sit at the desk.
Yeah.
But sitting at the desk is not really great for scoliosis either, and that exacerbated things a little bit. Even through, I tried to do physical therapy. I tried massage therapy. I did some injections in my back with anti-inflammatories with no luck.
What was the time frame of that conservative management in terms of injections, physical therapy? You mentioned chiropractic manipulation. Well, how long did you do that for?
I'd say 6 months to a year. I think when they give injections, you have to wait a certain period of time before you can get another one. Mm-hmm. And so I did that. And again, I just tried to keep working out and good core strength and rehab and those sorts of things. But it did not help at all. Nothing relieved it.
Yeah.
And at some point, the pain and discomfort became so bad that you said, "I need to do something different."
Yes.
Was it the pain that was the motivator, or?
Yeah, I think it was the pain, and my wife would attest to that. That my mental disposition was a little challenging. Not that I was. I don't think I was depressed, but it was a mental challenge to go to work every day and put a good smile on your face and have a good day.
Yeah,
it was a bit of a struggle.
20 years go by. You're treating your pain conservatively, and you get to a point where you just can't take it anymore, and you decide, I need to do something different.
Yes, and that's when I had a surgeon that I was working with that suggested the injections first, and then he suggested a procedure that I just wasn't real comfortable with. Just didn't have a real gut feel, and I thought, I don't know if that's a long-term fix. And I wanted something a little more longer term because I want to remain active and have a good quality of life. And so I reached out to my brother-in-law, who is a local ER physician, and asked him to see if he knew any specialists in the area. And that's when Virginia Mason came up, and Dr. Sethi, and then he specializes in scoliosis. And that's how I came in contact with Virginia Mason, Dr. Sethi.
That's excellent. Dr. Sethi, tell us about that patient encounter.
So I meet a lot of people like David, and people that have struggled with this problem for decades in this case, and get to a point where they need to do something different. And what is really important to stress at the outset is that every patient is different, and every patient's coping mechanism is different. Every patient's curve is different. Every patient's medical makeup is different. And so individualizing the program and meeting the patient where that patient is a very important part of doing scoliosis surgery. I think that many people misunderstand a lot of the work that's been published from Virginia Mason on multidisciplinary strategies, on optimization of patients, on centers of excellence contracts with companies with value-based healthcare. And I think the reason for that is a lot of the things that we do here are difficult to put in place at a lot of other centers. You need really a high-level buy-in from the executives in your medical center that you want to do this in a very robust fashion, so that you can individualize the care of every patient. And I try my best when I first meet a patient in the initial encounter to describe what that is. And Michelle Gilbert, who does the lion's share of the patient-facing aspects of this multidisciplinary evaluation, meets the patient at the first visit too. But part of this really is educating you so that you can make the best informed decision possible, but also talking about how serious some of the surgical complications can be for adult scoliosis surgery, and what we are going to do over the next 6 months or a year to mitigate those risk factors.
Yeah, and I think it's really a tough decision point for patients to know when surgery is the right thing. And Dr. Sethi, you've just talked about this sort of comprehensive care approach that you are lucky to have here at Virginia Mason that enables the decision-making to be optimized for the patients and for the doctors to figure out, is surgery the right thing? Can it fix the problem? And then what are all the factors that go into getting best prepared for surgery?
Right. One of the hallmarks of standardization of an approach is identifying what is standard work. So any surgeon at this institution that does spine deformity surgery, they follow a couple of standard work processes, right? So that includes measurement of a lot of the same variables. That includes looking at bone density. That involves looking at mental health. That involves looking at optimizable factors like diabetes and smoking. You would be amazed that I think in many centers, even these basic things are not corralled per se. So any if a scoliosis patient sees Dr. Levesque or Dr. Namani, for example, they would have the same evaluation that they would have with me.
And those are doctors in the practice.
Those are other doctors in the Virginia Mason spine practice, and I think that standardization really leads to enhancing patient outcomes, and we've studied and published that, but many others in many other areas of surgery have shown the same. And then getting those experts who can do something that maybe you're not so good at doing as a spinal surgeon. So one of the areas which we'll have David maybe talk about a little bit is a formal neuropsychological assessment that we employ here, and why we do that. And the reason we do that is, Michael Dobbs, who's now at UNLV, many years ago published, I think, some very important work showing that spinal surgeons, neurosurgeons, orthopedic spinal surgeons are very poor, have very poor judgment about psychological distress and very poor understanding of some of the mental health concerns that can make recovery from these surgeries quite difficult. So we employ a test essentially with a neuropsychological provider. This is really a psychologist who is talking to our patients and helping us to identify what does the home situation look like, what does the pain management situation look like, and what is the narcotic quotient there in terms of what do we need to address. Most importantly, what do they want to get out of this?
Yeah,
Expectation.
Patient expectations.
Well, that's a great point to say. So, David, you showed up in Dr. Sethi's office, and you had a really good feeling about this doctor.
Yes, I did right from the get-go, because he was he was just very honest. He was upfront. It was just straight up. And it was like, you don't have any much choice left.
Yeah.
This is what you got to do.
Yeah.
And I was a little shell shocked, but it's like, it's a risk reward thing, and like, it's worth the risk to me because I needed to change my quality of life.
Yeah, that's amazing. And so, Dr. Sethi, you talked about standardizing the approach, and yet every patient's different and unique. So standard approach, maybe Michelle can talk a little bit about what you mean by that.
Yeah.
In terms of bringing in outside experts to optimize the picture of the patient before they enter the operating room.
Yeah. So the first thing we do with a patient is sort of to get to know who they are as a person. And that's where the neuropsychology evaluation comes in. We get a number of sort of standard evaluations with DEXA, looking at bone density.
And why does bone density matter? Sometimes people don't understand why.
Bone density is a very important part of scoliosis surgery, because if you're instrumenting the spine, you want to be putting those.
What is instrumenting the spine?
Do you want me to start over?
No.
Okay.
Tell us what that means.
So if we're going to put screws into the spine in order to realign the spine, we want to be putting those screws in solid oak. Not in particle board.
Yeah.
And so it's very important to know that those screws are going to be solid, because there's a fair amount of manipulation, of realignment that's involved. And so all of our patients are screened for bone density, for osteoporosis. And if we identify osteoporosis, treated for osteoporosis prior to spine surgery. Optimizing that. So along the pathway, as we go through and we get to understand the patient, presence of diabetes or other medical conditions, then we sort of get a view of who they are just beyond the spinal deformity. And then all of that information is synthesized, and we meet monthly. We talk about patients once a month as a team. And present at that conference is our surgical team, a hospital medicine doctor, our anesthesia team. We have a dedicated team of anesthesiologists who do these important cases with us. Our pain management team, who does all the inpatient pain management after surgery, and then our neuropsychologist, and we all sit down and we talk about all these things, but more importantly about how do we keep this patient safe. and what are the things that we might need to work on or optimize before we get to the operating room, so that we can give this patient the best chance of meeting our expectations of.
David, did you have any idea that this number of people are involved in looking at your case and getting you ready to be in the hands of Dr. Sethi?
No way. It was so multifaceted. It was unbelievable. I mean, when I left, I have an appointment here, this next day, and I'm doing what, and they explained it all. I was like, holy cow. They're very thorough just to see if we want to get this patient to the operating room. That's actually reassuring.
Right.
That felt good. Like,
yeah,
I passed the test. I didn't study for the test. I passed the test. I felt good about all that pre-op stuff.
You got an A+.
I like to tell, along that line, I like to tell patients often, they know when the conference is coming. They know the date, and so they say, well, did I pass?
Yeah.
And the conference, it's not a pass or not pass.
Right.
It's what do we need to do, and how do we think about this before your morning of surgery in a very cerebral fashion, to prepare everything.
Intentional.
Exactly. And that's where that standardization comes in, that there's a standard pathway, but each patient is different. And we look at each patient, we spend time talking about each patient.
I would add to that a majority of patients that present with spine deformity at Virginia Mason actually end up with surgery eventually. There was a bit of misconception at some of our research societies when we first started presenting this work, over a decade ago, that this was essentially a rejection mechanism. That's not what it is. It's a lot of patients are put on optimization pathways, and they come back at 6 months after they've been on a bone agent, for example, like a Forteo, for example, or
explain again what is.
So some patients, we talk about bone density. If we identify that their bone density is not optimal for us to correct a spine deformity, then we send them to an endocrinologist, and the endocrinologist prescribes medications like Forteo to enhance their bone, right?
And that takes time for the bone to grow.
It takes time, right? Oftentimes it's that we need to work on things like weight loss, that we need to work on smoking cessation. Those things take time, right? So the vast majority of patients that present with a spine deformity at Virginia Mason get surgery. It's just a delay to the surgery.
Matter of time, when the time is right.
And we've published a recent article on this also in the Journal of Spine Deformity. Lisa DePledge, who's one of our students, is the first author on that paper on what are some of the reasons for these delays. And the reasons are medical status, right? And so...
Medical status meaning where you are.
Where you are. And so I would be very, and I again, don't know what David's scenario was, but I would be very worried if I went to a spine surgeon and they see a complex spine deformity and they want to get you on a schedule in 2 weeks.
Yeah.
I would be very worried about that as a patient, because even though I truly tell you got an A+, right? There are not everybody's like you. They've got issues we need to work on, right? And all of these factors. There have been studies we have done, for example, with the International Spine Study Group, a study that Doug Burton and myself led, where we looked at all these risk factors and we studied all the literature behind what can we do in various situations to get a patient to a better state prior to surgery. That, I think, is a very, very important part of enhancing our outcomes for these operations. Mm-hmm. There is the quote-unquote carpentry part, of how do you perform the surgery, where do you put the screws?
The masterful technique.
The masterful technique.
You can call it carpentry. We call it
masterful technique. The masterful technique part, I think, is I hate to say that it's a given, but it should be a given, right? That you're going to a surgeon who is very good.
Has the competency, has the masterful technique,
has the ability, has done hundreds of cases, fellowship trained, and if you're going to pick a scoliosis surgeon, you should ask him or her how much do they do, right? And they should be doing this a lot. And if they're doing that, they're going to be competent at putting the cages in the front like we did with you, or doing posterior column osteotomies or 3-column osteotomies. These are all terms to describe some of the advanced techniques that we use. But again, you got to optimize the host. That's the key thing. If you optimize the host, there is ample evidence now that you enhance the long-term outcome.
So using a carpentry example, it would be if you were going to paint a room, taping it off and doing all the prep and getting it all ready before you put the paint on.
Before you put the paint on. Yeah. That's right.
Yeah, that's a great example. So I want to talk a little bit about the scoliosis surgery, the masterful technique that you did. And we're going to show David's x-rays here. We'll segue into that as we're talking here, this sort of before and after. We have an expression that we use in the foundation where we say about deformity that curves that align make up your spine. So your spine, if you look at it straight, is straight. But if you look at your spine from the side, there are 3 natural curves. That's normal in everybody's body. In deformity or scoliosis, when you look straight at the spine, it's bent. It's curved, and the degrees of curvature are what you measure and look to fix. So when David came in, let's talk a little bit about that clinical presentation.
Yeah. So every scoliosis is different. I will tell you that we can group different types of spine deformity, and the adult types there are some that are longstanding, as in yours, and there are some that develop as your spine degenerates, which is unfortunately part of the normal aging process. As the spine degenerates, the discs, the facet joints, the ligaments, they degenerate. Oftentimes you have a situation of degeneration superimposed on a deformity you've had for a long time, which was, I think, the case for you. One thing that we do is we have a standard assessment. We have a radiographic or an X-ray assessment where we look at the spine really from the bottom of the skull all the way down to the long bones of the legs.
These are David's X-rays. On the left is his pre-surgery X-ray. David is standing up, and you'll notice the significant curve in his lumbar spine. On the right is his post-surgery X-ray. You'll notice the significant amount of screws and corrective hardware that Dr. Sethi has utilized to bring David's spine into alignment and straighten it.
Then we utilize MRIs and CT scans to, delineate specific areas. Several of us around the country now do 3D printing and 3D modeling of spine deformity. And as in David's case, we will build a 3D spinal model to plan how we will do the correction. So that was, how do you approach the spine? Do you approach the spine from the front, from the side, from the back? Sometimes we do all 3. Where do you cut the spine in order to get this alignment back? In David's case, your lumbar curve was approximately 55 degrees. And so we have to figure out, where are we going to cut the spine to get the alignment that we need? And the 3D model really helps. I also will utilize this 3D model in the operation because I teach fellows. I teach other surgeons how to be spine deformity surgeons, and most importantly, to enhance the speed of surgery. That can help you with placement of screws. We put screws in these bones to correct them, to derotate the vertebral column, sometimes to straighten the vertebral column. And then putting these screws in very abnormal pedicles sometimes, which are malformed sometimes because of the actual spine deformity. Sometimes they are really, really hard pedicles on one side of the spine and softer pedicles on the other part of the spine. So you might need to use something a little bit different. A drill versus what we call a gear shift. I'm getting into the carpet.
Yeah, this is the master.
Yeah.
So, and we're so blessed today to actually have the 3D model that you used for David's surgery.
Yes, we have it here.
And let's show that to our listeners.
Sure. This is a 3D model of David's spine. It shows the deformity of his lumbar spine, and this is the portion that we would call the concavity. We would call this portion the convexity. And oftentimes, as in David's case, big reason they want to go to surgery is on this side of the spine, you get what's called a fractional curve. And that fractional curve causes pinching of nerves. And they start to get symptoms in their legs and their feet. Sometimes it can be shooting pain. Oftentimes it can be what's called a dysesthesia or painful numbness. Oftentimes it can be weakness, depending on how severe the curve is. But when they start to get symptoms in their legs, that's a common reason for them to go and see a surgeon. What was in your estimation the reason that you really wanted to proceed to surgery?
Well, it got to a point where, again, the pain was just constant. It wouldn't go away. Nothing would alleviate it. And then I started getting numbness in my toes. And then more frequently, I would get acute muscle spasms, too, that would just tighten my low back up. And it became very uncomfortable. And that's like, okay, I've done this long enough. I got to do something.
Yeah. And so when we plan, we have to obviously reconstruct the spine and the coronal plane, which is looking at it from the front. But more importantly, we want to rebuild the sagittal plane, looking at the spine from the side, to redistribute what we call lordosis, which is when you look at the spine from the side, it's the shape that Rita's talking about earlier, to where the patient is standing up straight, and also putting lordosis, or that curve, in specific portions of the spine where it should be.
Lordosis is something that people can understand. It's that curve in the lower part of their back that oftentimes we say you need lumbar support or sit in a chair.
Some people call it a sway. Yeah, some people call it a sway. And so what we've learned in the last 15 years is we really have to focus on the lower part of the spine. We measure parameters. There's a parameter called the pelvic incidence, and we know that we need to dial a certain amount of lumbar lordosis to match that pelvic incidence. But we have to really focus on this bottom area between L4 and S1. And you can see here that a lot of David's problem is his spine is collapsed on this side, and that's where he's getting a lot of the nerve symptoms. But also,
this is his hip bone, right?
This is his pelvic bone here. So this is the hips. The hips more down here. It's not on this image. If you look at this from the side, we really need to rebuild lordosis. So that's a big reason why I am a proponent of an anterior approach at the bottom two levels. And that's what we did in your case. And then the second stage of the operation is a posterior approach, where we approach the spine from the back, and put what we call pedicle screws and iliac fixation in to complete the correction. The reason I really like the 3D modeling is it helps you demonstrate to your team in the operating room, particularly the fellows that you're teaching, where you're going to cut the spine and how you're going to cut it. I do think that this helps to individualize the surgical care of the patient.
That's incredible. That sounds like a very big operation. And
Yes.
and Dr. Sethi, is that all done in one operation? So you do part of it from the front and turn the patient over and do part on the back? Are those 2 different days, or what?
Sometimes we do it all in the same day. Sometimes we'll do a small portion on one day and then the major portion on a second day. It really depends on the actual specific patient. Sometimes I like to just do anterior approaches or lateral approaches. Go and talk to the patient afterwards and make sure that their leg symptoms are better. Many people feel the leg symptoms go away almost immediately.
Yeah, that mine was a 2-day procedure. But,
Yeah,
I didn't feel.
And I think the reasoning for staging in many cases is we know that 10, 12 hours of anesthesia is not good for patients. One of the things that we try to do is we do a very short anesthetic, and then the next day do a longer anesthetic. If I can do the entire operation, meaning the ALIFs and the posterior correction, in under 8 hours, I'll do it at the same stage. In complex or more difficult deformities, it's hard to do that. will do the anterior portion on one day, and then the next day do the posterior portion.
That's amazing. And so, Michelle, your job is to explain all of this to the patient,
Yep.
right? And translate that.
And that happens over subsequent visits, right? If you were to come in the first day and we went over every single detail, it'd be overwhelming. And patients need time. They need time to talk with their family. They need time to absorb. And we do that over a number of different methods as well, because we know that patients learn best when they hear it. They learn best when they see it. They learn best when they read it. And so we have some written material for patients. And so then we go over all of it. My hope always on that last visit before surgery is that everything's reviewed, that we're not talking about anything new at that point, that the patients we're at a place, it's a few weeks before surgery, and patients understand what the plan is, what the expected outcomes are. We've got a good plan in place for what after surgery is going to look like.
That's a lot. And that speaks to, again, the multidisciplinary team you have here, highly trained physician assistants. We've talked a little bit about what those aspects of the care of the patient are. And that's something I think that's unique here that you've developed.
Yeah. So I think there are many centers in the country now who have really formed these spine teams or complex spine teams, which includes specialized advanced practice providers, PAs, nurse practitioners who deal with the spine and who are very, very closely attached to the programmatic activity of the group. And so basically this is like an institute model, essentially, where there's a vigorous effort to provide multidisciplinary care, and there's a vigorous research and academic arm to studying what we're doing and making sure we're doing something that we've used it at Virginia Mason called Kaizen, which means continuous improvement. So you're always improving your processes by studying what you previously learned.
I think sometimes patients can be confused about what that means to be researching what you're doing. Nothing that you're doing are things that have not been approved by the FDA for use in patients. So we're not looking at things from that perspective. We're looking at
experimental.
It's not experimental.
That's right.
So can you explain that a little bit?
So Rita, very good point. Everything that's done, in an operating room has been, or every screw that's put in, every cage that's put in, every bone product that's used, every bone protein that's used, these are all FDA approved products. I think that what one has to realize is that the scoliosis surgery, adult scoliosis surgery of 2023 is very different than the adult scoliosis surgery that was done in 2013. And I would hazard a guess that 2033 will be very different than 2023. And so an institution or a unit that does adult deformity surgery, I think, needs to be constantly adapting to what's new, what's current, what's got the best evidence behind it, and be able to pivot towards that. And I think that an internal structure to study what you're doing is absolutely essential to providing that continuous improvement.
And that excellence in patient care.
Absolutely.
Yeah, that's exciting. So we've talked about the awareness of a problem, the diagnosis of the problem, identifying the right care team to get you there. The patient expectation for outcome is a big piece of that. So let's talk a little bit about what happens after surgery, what recovery looks like, what getting back to your life means, and how you get there, and how your care team continues to support you on that part of the journey.
The thing we're hoping to provide, and I think we do really well here, is resource for the patient, and that's where I get in my role to be that person for the patient. If you've been a patient anywhere, sometimes you pick up the phone, you're like, how do I get a hold of somebody? Who do I call? Then I get rerouted to this person or this person. I get to be the person who supports patients and helps them through the journey. And it's such a gift to be able to do that. So,
yeah. In my case, I felt very individualized for the fact that I was talking to a real person. I didn't go to the main switchboard and they go, well, you hold here. And I'd always talk to the same person all the time, and it was close, and it was just very personal. It was a long journey, and Dr. Sethi told me, you're not going to like me for about 3 months. And he was right. That's right. It was a challenge, one of the biggest challenges of my life, to go through that. But I appreciate the honesty. It wasn't a surprise.
Yeah.
And I knew what was coming, and I got through it.
The expectation of what's to come.
Yeah.
Might not like it, but
Nope.
it's like you tell your kids the shot's going to hurt, but then you're going to stay healthy, right?
Yep.
So
Right.
the temporary, step here. And so with the recovery, when does recovery start? Does it start in the hospital? What does that picture look like? And what did it look like for you, David?
Well, it started right away. Again, you wake up in your room and you go, did surgery happen? Yeah. And like you try to move and it's like, oh, yeah, something happened here. And it was kind of a shock, quite a shock. But one of my things was I had a little bit of a complication a couple days later, which I guess is quite common, very common, is I had an ileus, and I didn't know what an ileus was. And that's when your bowel stops working right.
Yeah.
And it didn't wake up for a few days, and that caused that was a challenge more than the surgery itself. But they said, just keep walking the hallways, and that's what I tried to do, just walk the hallways with my my IVs the way I would.
Deep brain.
Oh man, that was a battle. But once that subsided, it left me in the hospital an extra 3 days, which wasn't real pleasant. But once I got home, I felt a lot better, and I was able to move around. And thanks to my wife, she got me to the track, the local track, and man, I was walking every day.
That's actually amazing. Actually amazing. So you're up and out of bed in the hospital the day after surgery.
Mm-hmm.
Yeah, I was like, we're going to move? Like, okay. And they know me. It was a bit painful. I was like, God, are you sure this is fine? And yeah, they said, get up, let's move.
Early mobilization is very important after all types of musculoskeletal surgery, but particularly spinal surgery. Our physical therapists are very, very astute at moving people, immediately after surgery. Yeah.
That's amazing. So walking every day for your healing. You mentioned your wife was there to support you and promote that. And I think, Michelle, you touched a little bit on that with that neuropsych evaluation preoperatively, is looking at what does the support system look like at home, because you're going to need support, and making sure that that's optimized for patients, because again, that's going to be a big part of the successful outcome of the masterful technique that's delivered.
Yeah, we ask patients to identify who their caregiver will be. Sometimes it involves coordinating, a family member who doesn't live locally to come be in town. And so there's a lot of coordination that comes into identifying who that person is. And then there's an education for that caregiver as well. Preoperatively, our patients do a education class with our nursing team. And that's just as much education for the patient's caregiver on what to anticipate after surgery, what the recovery looks like. And so that's an important part of our pathway.
One of the things also that we actually did here many years ago, and have also written and published this, is the importance of having advanced nursing involved in your program. And so, David, I don't know what form of it you went through, because now post-pandemic we have a virtual version of this.
Yeah,
was an education class where you attended with probably your wife or your loved ones, where they went through a little packet of all the things that you will go through and what to expect, really on the patient journey. When you may have gone through that prior to the pandemic, where it was in person, but now a lot of it's done via web and and Zoom. But it is overwhelming to get all this information and then digest it, and so we really want to make sure that there's a refresh on that. And so here in this clinic and on the complex spine service at Virginia Mason, it's all done by one person. One nurse runs that. Yeah.
Interesting.
Yeah, I'd just like to reiterate again, the support system's huge. My wife was awesome. I mean, the encouragement, the support, keeping me fed and dressed, driving me to the track every day.
Managing medications.
Yeah, meds. I didn't have a clue about meds. She just take these. I said, okay, the boss. That's what we're doing. I had neighbors, mowed my lawn. It was great. Yeah.
Wonderful. How much time off work did you have?
I left. It's about 6 weeks. luckily I was in a staff position where I wasn't on the streets, so I was able to go back to my desk. And that's another thing. My employer was very, very flexible, accommodating, understanding of my time away, and they kind of filled my position while I was gone, and I was able to come back, no questions asked.
And so much of the time we talk about the miracles of modern spinal health care, being able to help people get back to the people and activities they love. So that means being able to get back to work if you want to get back to work. And 6 weeks after this major, major surgery, all of the planning and preparation getting you to that point, 6 weeks of recovery, you're back at work.
Yeah.
A miracle.
Yeah, it was.
A miracle.
It really was.
And how'd you feel?
Relieved, just to be out of chronic pain, be able to sleep at night, sit, stand, walk without that pain. And, I had obviously some numbness, but things regrow, and it's still happening today. But what a relief, man. It was just a heavy burden on me.
The onus of chronic pain, particularly with major spinal problems like spine deformity and scoliosis, is a very, very difficult one for many patients. And we see patients that have been on narcotics for sometimes double-digit number of years. And those are the hardest cases because there's a rewiring of the central nervous system. And when people are on those medications for a long time, their outcomes are just not as good. That's been published by many different groups. And so intervening at the right time is very, very important. And I think that, the multidisciplinary evaluation involving anesthesia pain, involving really a complex spinal unit that everybody's talking about these cases together is essential. We have patients that come to us from all 50 states here where sometimes they have really been in a difficult, challenging environment around narcotics, around help for their condition, and really stratifying all of that and getting them to surgery properly is very, very important for good outcomes. And I think one of the things we're also, Rita, to your point, blessed with is that our industry colleagues have done an incredible job with helping us get implants in minimally invasively, for example, getting better planning tools out there to plan these deformity corrections. That can be 3D modeling. It can be, there are so many great tools out there to assist surgeons to do a better job in their planning of surgery. And so we can execute great operations now.
Innovation has been phenomenal. Mm-hmm. And you talked about being mindful of the innovations and looking at what is new and what is effective and what is best for patients. And that what did you call it? Continuous improvement. What is
continuous improvement?
Continuous improvement. Yeah. Part of your practice. Mm-hmm. So critical in spine. That's a field that's evolving and innovating so rapidly and so incredibly for patients. That outcomes can be overall good for patients. So when David completed his surgery, he's getting discharged from the hospital, what things did you tell him he couldn't do anymore?
Yeah.
His back is fused. He's got lots of hardware in there.
So there is a certain amount of flexibility in the lumbar spine that's lost from this. And we often tell people that you'll make up for a lot of that with your hips and your knees. But that takes time. It takes, in many cases, a year or more. A lot of people will have difficulty crossing their legs. A lot of people will report that they feel stiff in the morning, and that works itself out over the day. But one of the things that's really the best part of adult deformity surgery is the pain relief, because stabilizing the spine in a correct coronal sagittal alignment, which is the front and the side, as we discussed. And obliterating motion at these severely diseased and arthritic segments provides very predictable pain relief, and that's the best part of the operation. certain people, I have, and David can be my judge on this. He's a very physically vigorous, active person. I would tell you that, when I see a patient at 6 months or a year, and I like the X-ray and they've held everything together nicely, which the majority do, I will say there's no restrictions.
Wow.
Yeah.
Playing basketball?
I'm not playing basketball anymore.
Pickleball?
I'm playing pickleball. I play racquetball. I cycle. I bike. And I golf. And I water ski and I snow ski.
Oh my gosh.
Just very active. About the only thing I don't do, and I really don't miss that much, is running.
Okay.
But I ran for 50 years. And, it did its toll.
Yeah.
And I really don't miss it that much. So, but there's other alternatives there.
Sounds like you've got a lot of fun alternatives.
Yes, I
there.
do.
That's awesome. That's fantastic. Closing comments, things that we might not have mentioned that we'd like to share with our listeners. I'll start with you, Michelle.
I think that one of the things I really appreciate that we touched on today is the time that you spend with the patient, listening to them, hearing their story, and then the thing that is so rewarding for me to be a part of it is getting to be a part of people getting back to active lives. That we do the surgery so that people can go do the things that they want to do. And so, my advice would be, find a place where you feel comfortable. You've got a gestalt, and trust in the surgeon and in the team, in the process that the team, because you're going to spend a lot of time over the course of the pre-op and the post-op, spending time with the surgeon and then the team of people who will take care of you. So make sure you feel like you have confidence in them and that you spend time with them listening to you.
I'm extremely grateful. The staff here at Virginia Mason, from Dr. Sethi all the way down to all the nurses, everybody that was involved that I don't even know about, was just tremendous. Throughout the night, whatever, that was just tremendous care. I didn't join my stay for 10 days here, but I tell you what, it was quality care, and I really appreciated that. I'm not going to say Dr. Sethi saved my life, but he sure improved the quality of my life to, umpteenth degree. And one thing I would like to mention too is one of the things that really helped in my recovery and still is today is I get massage therapy, and I think massage therapy has been extremely helpful for me. I get it a couple times a month still, and I can tell the difference if I don't get it, and that's really helped in regrowing things.
Yeah. And how many years out from your surgery?
I'm 3 years out. Yeah. Extremely grateful.
Yeah.
Well, so first I want to thank you, Rita, and I want to thank the National Spine Health Foundation for really doing world-class and leading work and being patient-facing and really telling the story from David's perspective and so many other patients with spinal disorders. This is something that we've needed for a long time, and I'm really happy to be involved with you on this journey, and really want to thank you again for doing that work. My message to spine deformity patients like David is that this can be a very difficult process for you with the chronicity of the problem. It's something you've struggled with for years. And how do you make that decision to move to the next step? We have world-class surgical approaches now in a lot of great centers around the United States and the world. Many of us are connected through our academic efforts, through in the case of spine deformity, through the Scoliosis Research Society. You can look at some of their materials to choose the right surgeon. But I think in terms of choosing that surgeon, look at a couple things. Look at how many procedures does that surgeon do? What does their center look like? What do they have a process of continuous improvement where they're looking at what they do? Do they participate in academic activity? And then get a second opinion if you don't like what you hear. I think that is my advice to any patient with a spinal disorder. And in many cases, there is a great operation for you. And it's just getting to that group and that person to do that. And there is a tremendous amount of hope. with the efforts of our research groups, the efforts of our industry colleagues, and really it's a worldwide effort, the spine care gets better and better and better every year. And so I'm really, really bullish on our future, and our goal is to really get rid of any suffering that we can get rid of. And that's why I do what I do, and that's why I entered this profession, and that's why I have zero burnout, and we'll be doing this for a long time.
Well, this has been a remarkable conversation. We've never done this. Dr. Sethi, you have your patient with you today. I don't know how often you get to have the joy of living, seeing life after surgery and the wonderful lives that you're able to restore and improve. And thank you, David, for coming today. Thank you, Michelle, for all that you do, for helping to organize us today. We say that, Dr. Sethi, you and your team are healthcare heroes. You put the best of science into practice every day to deliver excellence for your patients. And I thank you for your leadership, for taking the time to be with us today, for organizing this panel. It's not easy to do this, but there's a real commitment here to educating patients and our desire to give hope to people who are suffering, that there are answers out there and you can get out of pain. There's hope. So thank you, Dr. Sethi. Thank you, Michelle. Thank you, David. Thank you to the team at Virginia Mason for letting us come and disrupt their conference room and the time. And we will share this good news with the world.
Thank you.
Thank you.
Thank you.